So, first, what is COPD? Well, you've learned a lot about COPD this morning, but how does it behave? In other words, how does it affect the people that are affected by it? The characteristics of it as a chronic illness. And what kind of tools do we have to treat people with COPD? And with all of that information, kind of not think about all of the systems that you have been given thus far this morning, and say, well, how would I design a system of chronic care for COPD patients, knowing exactly what happens to them and how do they suffer? So, first, the disease progresses. It's chronic and progressive. We don't have a cure for it, but people like Dr. Casaberry here have provided us with a whole bunch of things, including several of my slides, that will help to give us insights as to how we can do things for COPD patients. But we don't have a cure. But we do know that patients become deconditioned. Why? Because it hurts when they try to breathe, and they and try to go upstairs when they try to exercise. So they avoid doing that which hurts. And then, of course, the flare-ups of the disease. We call them exacerbations. Sometimes our patients call them exasperations. But in any case, flare-ups are a part of the overall picture. Patient doesn't suffer from the lung or the deconditioning or the flare-up. Patient suffers from all three. And it's hard to distinguish. In fact, it's impossible to distinguish from day to day what is really affecting these people. Okay, now, I happen to enjoy doing digital animation, so here it is. So what is COPD? Chronic bronchitis. A component of asthma, although asthma itself is a separate disease, and a component of COPD. And this whole rectangle here represents airway obstruction. But there's a lot more than airway obstruction involved in this disease. One of the problems is that in emphysema, for example, the alveoli that tend to tether the airways open are kind of destroyed. And so what happens is those airways, which are escape routes for air that's supposed to be leaving the lungs, get obstructed by closing down. And if you take a person with heterogeneous disease, and I'll keep my pointer right here, as a person starts to exercise, because they tend to trap air, and they breathe more rapidly during exercise, they start to, the emphysemic portion of the lungs start to crowd out the more normal portion of the lungs. And the way I describe it to people is I say, take a real deep breath. Some of you try to do this. Take a real deep breath, and then do all your breathing at the top of that breath. It's uncomfortable, but this is what a person might feel like if they trap air, and so this prevents them from wanting to exercise. And what happens is that their end expiratory lung volume, instead of being here where it should be, tends to rise. Now, also involved is the fact that emphysemic airways, or air sacs, and more normal air sacs fill and empty at different rates. And when that happens, then there tends to be a collateral circulation between the emphysemic portion and the more normal portion. So instead of going in and out of the system, it goes back and forth within the system. And that's not really good for gas exchange. So, person who is sitting in front of me changes over the course of years, either through the natural process of aging or the disease process, or both. And if they smoked a lot, they might end up with emphysema and requiring oxygen therapy. Now, so looking at the disease characteristics, and you've heard a lot this morning already, but airway obstruction, gas exchange loss, hyperinflation, muscle weakness, due for a variety of other reasons, exacerbations, hospitalizations, and respiratory failure. Now, if you take a look, and I loved the fact that Guy Suhu was telling us that there is a clinical description of the disease with the VA system. That's exactly what it is. It's a clinical disease. Yes, we can measure all kinds of things, but how it affects the patients is really clinical, and you can determine what you want to do for those patients based upon that. So a person's at risk. At some point they become symptomatic. You know, do you get short of breath on climbing stairs? Well, gosh, I don't climb stairs. I mean, I'm 50 years old, too old to climb stairs. No, it's the disease. Get exacerbations, respiratory failure, and we have an arsenal of care. and smoking cessations, vaccinations, prevention kinds of things, long-acting, short-acting bronchodilators, nutrition, exercise, oxygen, all these things are helpful. Every one of these things are helpful, and you put them all together, and you can do an awful lot for a person with COPD if you design a good system to do so, including the surgery option, which is appropriate in some people, and palliative care towards the end of life. People should not end up their lives on a ventilator. This is just wrong. And then finally, we come up with a clinical philosophy. If we're going to design a system, we've got to have a goal in mind. Well, the disease is chronic and progressive. We know that. But all components are treatable, including comorbidities, and that patients can live active lives, and they should live active lives. Emergencies are preventable, hospitalizations are preventable, and basically overall, that clinical course can be modified. So, as the disease progresses, like I showed you before, what would our goal be? Our goal would be to delay the impact of the disease. The impact will occur, but we'll delay it towards the end of life, and perhaps increase the length of life. We've never proven that we actually can do that in every case, but certainly that would be a really good goal. And those of us who treat COPD patients, especially who do pulmonary rehab, really do believe that we're extending life. So it'd be nice to be able to prove that. So the FEV1, the amount of air you can blow out in 1 second, is one of the indicators of airway obstruction, tends to go down, but symptoms increase. But where are the landmarks? There are no landmarks here. Really, the landmarks are here. We see them. The patients are telling us they don't have any symptoms, or they get to a point where they have symptoms, or they get to a point where they have exacerbations, and eventually they get to a point where they have respiratory failure. Now, can you have an impact on this progression? Yes, you can. Or how it appears with that progression. Certainly prevention, like smoking cessation. Disease management, which is the overall description, although we're not doing disease management like insurance companies do with banks of nurses that you call. In fact, one study of the Medicare system actually showed that it wasn't effective recently. And then, of course, the other options, including NPPV and surgical options, are certainly there. Now, we take a look at this set of guidelines. This is from the website of the ATS, American Thoracic Society, European Respiratory Society guidelines. We have all kinds of things of what to do. The question is how to do it and how to be effective over the lifetime of the patients. So we take scientific and expert opinion and we go to disease control. So we have to build that bridge. So, living patterns affect disease control. This slide, I hope I don't offend anybody, this slide is subtitled, Say No to Crack. If I did, you can be properly offended. Anyway, now, when you're trying to modify behavior, generally, the way we look at things is over the short term. So here it is, the short-term benefits. Kind of like dieting. Dieting works, right? Seems like it's working. You lose weight. You stop eating, you lose weight. But is it a good long-term solution? Everybody knows that it's not. Pulmonary rehab is really very good. It's very effective. But it is not a long-term solution unless we can design it such that we can make it into a long-term solution. So let's say over a period of 10 years, there might be a different way of approaching the patient and approaching the whole system. So if you look at it as the area under the curve, as your metric of effectiveness, the area under the curve here would be much greater than the area under the curve here. What we do is we teach skills, habits, and routines. Okay, so we don't even have to have a person who's cognitively intact. In fact, one of our best patients was not cognitively intact. What we do, we provide this system where they learn a skill and they practice a skill. Typing, riding a bicycle, riding a unicycle, flying an airplane. All these are skills that have to be practiced over time and reinforced over time. So when you're describing a system, this is a map of our COPD system, including the goals that we have, the advantages of a group setting. We have a support group run by my partner who is a nurse, who is a real specialist in rehabilitation. And then our components of care that I described to you on an earlier slide, then we come up with a set of daily rituals. This is the sort of the sum total of things that people have to do on a daily basis. Okay, that's the least common denominator of control of the disease. And on a daily basis, for example, taking their medications, getting up in the morning, taking their medications, and so on. I'll describe it in more detail in a moment. And then come up with an office protocol which looks exactly like the daily rituals, except that we're going to check them out and give medical decisions based upon what we observe. So this will be monthly visits. Patients come to us with monthly visit, and we reinforce a set of skills, including their exercise, including exacerbation protocol. So here are some of the core components. Certainly, we want people to quit smoking. Okay, this is from the Gary Larson cartoon, Real Reason Dinosaurs Became Extinct, because they smoked. That's one of the theories, by the way. And what about secondhand smoke? Now, this horse never smoked a day in his life, but he lived with a Marlboro Man. Oh, thank you, Rich. What does exercise do for us? Exercise helps our patients to be able to do more with breathing less. Okay? When you breathe less, you're breathing less frequently. So here's the less frequent. And when that happens, they have time to empty their lungs for the next breath. So in other words, they can exercise to a higher work rate. Am I okay with this, Rich? Okay, thank you. You let me know later. Okay. So they have more room to breathe. And when we did pulmonary rehab starting in 1968, that's was my first pulmonary rehab program, I had no idea that what I was doing was helping the lungs. I thought it was helping general conditioning. And it was Rich and some of his colleagues that taught us, yes, there is a pulmonary limitation. Okay. And then we have studies that have shown us that in terms of survival, people who need oxygen by our usual criteria, physiological criteria, but they don't take oxygen, have poor survival. But in a dose-dependent fashion, as they increase the usage of oxygen, their survival gets better. And if they have oxygen most of the time, in some cases all the time, but most of it was most of the time, then their survival was even greater. And these are just major studies that have shown that in terms of survival, oxygen therapy is really a very potent therapy. But in looking at some of the studies for the NOT studies where they compared 12 hours a day with oxygen continuously, patients who didn't take their oxygen continuously, in other words 12 hours a day, and were inactive, had a lot of days in the hospital. If they took continuous oxygen therapy, they had fewer days in the hospital. If they were more active, they have even fewer days in the hospital. And the combination of being active and having having oxygen most of the time, they even did better. So this is in terms of number of days in the hospital. Now, again, thank you, Rich. Patients trained on room air do very well. Patients who don't need oxygen trained on room air do very well. Patients who don't need oxygen but trained on oxygen but tested on room air did even better, 38% better. If you think about what it takes to come up with a new medication for hypertension, if you improve hypertension by 5 millimeters of mercury, you think you have a very, very good drug, and people pay hundreds of dollars a month for that drug. Here, oxygen, which is not that expensive, in addition to exercise, is very, very useful. So in other words, we can do an awful lot for these patients. Okay, again, thank you, Rich. We have the combination of pulmonary rehab, where exercise is improved on a pulmonary rehab program, because most of them are based on exercise plus self-management, plus a lot of other things. But if the person also gets a bronchodilator, in this case it's tiotropium, they do even better. And look at how much better. And look at how the curve separates towards the end. So it really makes a big difference. So we now got exercise helps, exercise plus oxygen helps, exercise plus bronchodilators helps. Now, one study showed that exercise helps, plus oxygen, plus bronchodilators, plus both of them even help more. So in other words, there's an awful lot that we can do for these patients. But wait, for the first 20 people who call, we've got one other doodad here, and that is pursed lip breathing. Pursed lip breathing, guided by oximetry, actually can increase the person's oxygen level. Okay? It reduces their work of breathing per minute. This is the work loop for a normal person, and the area inside that loop describes their work of breathing, more or less. And then a person has emphysema, they have to work hard on exhalation because they have to try to push that air out. But if a person does pursed lip breathing, they breathe more slowly, but they breathe with higher work loops and put a little bit less pressure during exhalation. So they can actually improve their work of breathing per minute. And so we did a study published back in 1986 showing that if a person does training with pursed lip breathing, non-pursed lip breathing does this. Pursed lip breathing increases a person's saturation. And in fact, a person with normal lungs on top of Mount Whitney, I measured it myself, I went from a 72% saturation to 88% saturation by doing pursed lip breathing. Okay, there's something else, and this is hot off the press because I generated these curves last week. If you take a look here, let's see if I can study this. If you take a look at exhalation of CO2, this is what it looks like. This is what the curve looks like when a person exhales CO2. But if they inhale, let's say they exhale through their nose and inhale again through their nose, in other words, through the same orifice, then they inhale more, they re-inhale some of that CO2. And this is what this shaded area represents. However, if they do pursed lip breathing, and this is all by lung models and CO2 models and so on, by doing pursed lip breathing, they inhale less of that, re-inhale less of that CO2. So in other words, pursed lip breathing both helps oxygenation, and also CO2 removal. Okay, now what about exacerbations? Exacerbations is the reason that these people get sick, they get hospitalized, and the reason a lot of people die from this disease. Well, an exacerbation is an acute event, acute on top of chronic. And so what happens when a person has an exacerbation, they get inflammation along the airways, they get infection most of the time, so the infection plus inflammation then leads to damage, destruction of the linings of those airways. So it's a dynamic process. But when people have an exacerbation or flare-up of COPD, a lot of times they ignore it. Then they call their doctor maybe a couple of days later. The doctor gives them an appointment a week from Tuesday. And for some reason, they ended up in the hospital even though they had a doctor's appointment that they could have done it a different way. And obviously, we have a different way of doing that. A person who has frequent exacerbations is more likely to have disease progression. So, an exacerbation, it involves disease progression. It also involves the disability and worse chronic, quality of life. Another exacerbation is more likely, and a person is more likely to die from an exacerbation of COPD. And it also increases the cost tremendously. That's where the big cost of COPD lies. So that's the downside. Well, is there an upside? There better be, because I still have half a slide left here. The rapid recovery. Early intervention, you can have rapid recovery. You can prevent further hospitalizations and exacerbations. You can prevent disability, and you can prevent another exacerbation, and you can lower the cost of care. So that's the upside. So when we work with COPD patients, the bottom line is what the patients do at home. How they manage at home makes the difference. It's got to be consistent and persistent, and it's got to be timely. Can't wait till a week from next Tuesday. And for example, if you take a look at the overall system, we prescribe medications. We assume our patients take it. That's not true. That's not true 50% of the time, according to one study. And inhalers. Even professionals don't use inhalers adequately or optimally. And these are great medications. They're very expensive, but most of it goes to waste anyway. So we want to try to reduce the amount that goes to waste and make these more effective. And oxygen therapy. Well, some of you patients are in the room. You either know or from your own experience or from the experience of your friends who are in pulmonary rehab groups with you that they don't always take oxygen as prescribed. And that's not surprising either. So our job is to, in part, reinforce these things that we know we can make a huge difference. So, in COPD, we tell patients, your job is self-management. So what's our job? Our job is to make sure you do your job. Whoops. Yeah. That's it. No. That's it for that slide. I'm sorry. Now, that's the background. I got the biggest laugh for the non-joke. Okay, anyway. So our chronic management model involves first getting up and getting dressed. People with COPD don't feel like getting up and getting dressed in the morning, stay in their pajamas. Taking medications as prescribed and effectively, and oxygen therapy, coughing and clearing secretions, those people who have that, and we can help in that way as well. Pursed-lip breathing makes a big difference. Walking, or daily walk, that's a huge benefit from just the walking portion of it. But at the end of a walk, check for a flare-up. Why do we check for a flare-up at the end of the walk? We always say, flare-up. How do you know if there's a flare-up? Well, if a person has a daily walk, they know right away. All they have to do is try to walk that next day and find out that they can't do it, and they're more short of breath, and they think, well, I'm starting to produce these secretions. Maybe I'm having a flare-up. So they start the rapid action plan, which is to call the doctor, in my case me, and start the prednisone, because it's anti-inflammatory, antibiotic, bronchodilator, we like Combivent for a short-acting bronchodilator, pursed-lip breathing, oxygen, we also increase or encourage fluids. And so a lot of people don't want to take steroids because they're afraid that it's going to make them look different. But if they take steroids over a short period of time, we minimize that effect. Okay? So it's important to know what the lungs, the heart and the lungs look like, and the fact that they do work together in the same system. I hope you enjoy this slide because I filmed it on location. For those of you who don't know, this is a Mars landscape. And the skills on how to take their medications. Now, we have a lot of different kinds of bronchodilators, but it's important that the medications, like this cloud right here, gets down to where it needs to go. And if we can do that, we can make a big difference right away. Okay? Also checking for secretions. I like to do this before lunch here. Okay? You're clearing secretions, and they're sort of getting more purulent. In other words, there's an infection involved. So right away, start the rapid action plan. And this is from the Wasserman slide, except that it's going backwards here. He let me know that. But anyway, so oxygen enters the system, but it's got to go through circulation, it's got to go through muscle. And the muscles and all the tissues that are fed by this system have to be able to uptake and utilize the oxygen. So oxygen transport is this whole system. And what helps this whole system? By this time, our patients are all saying in unison, exercise. So learning is a process. It's not an event. And when we give an event, like a classroom, like what we're doing right now, then you might as well plan on it being forgotten. A week or two, or a month or two, or a year or two, definitely, down the line. But if you're working with a system that's got to work for the lifetime of the patient, then the system itself has to work for the lifetime of the patient. So, as the disease gets worse, as the disease progresses, you expect us to be less effective. Actually, the patient can be more effective through practice, up to a certain point, obviously. And so it's not like medical school or respiratory therapy school. It's like the practice of medicine. So, the core construction is our clinic, which is, we call it the doctor's therapeutic office visit, and that's because we don't just examine the patients, it's a therapeutic or training visit, and it goes over time. And we go through the inhaled medications, the clearing of secretions, pursed-lip breathing, walking, we check for exacerbations, and I make rounds at the end. We do adjust the self-management, and I bill it simply as a doctor's office visit. So I'm not trying to fight for rehab funds. I'm saying I'm doing what I consider the right thing for an office visit. It's inexpensive. In fact, it's less expensive than standard care, and it doesn't involve any other kinds of expenses as well on top of that. So what are our outcomes as I'm wrapping up here? Over 10 years, this is our 10th year, we have 154 patients who have walked through our doors. In some way, 112 patients participated. 81 patients had almost 1,100, we're actually close to 1,100 exacerbations or flare-ups, resulting at about 41 hospitalizations in total. Now, 46 of these people actually had previous hospitalization for exacerbation. So you can see where I'm going with this. Now, we have two comparison studies, done for different reasons, but they recorded hospitalizations for flare-ups. So, this particular one, nearly 1,000 exacerbations and 260 hospitalizations. This one, this is from Claudia Cote and Barcelli's group, and they were looking at the BODE study, the BODE index on this particular one, and they had this number of hospitalizations for exacerbations. We've got 1,100, and we have 41 hospitalizations. So in the other two studies, it's about 27%. In our study, it's 3.8%. So we think we're making a difference. So when a patient has a choice, they can either let the disease take its natural course, and we all know where that's heading, or the person could be active, could be involved, can have a regular reinforcement system, and they could not be necessarily like these people, like this is Roxlyn Cole in Denver, who does several times a year a half marathon on oxygen, 16 liters per minute, pushing that cart, or Mike McBride, who did the Boston Marathon. All these people have COPD, but they live to exercise. And when they do that, and when they're so extreme, we really do know that it is possible for these people to do better, even with FEV1s that are down. So, in effect, our clinical philosophy is that the disease is chronic and progressive, but all components are treatable. Patients can live active lives, emergencies are preventable, hospitalizations are preventable, and the clinical course overall can be modified. So I leave you with this slide, and this is our respiratory support group, where patients are out of bed, enjoying a nice lunch, listening to some very bad jokes, and listening to my daughter and I play the violin and mandolin for them. So thank you.